Yes, it's almost 6:30. Okay. So as of now, we have around 30 participants. I hope by, when we start the session, we'll have more incoming. So good evening, one and all. Welcome to yet another rapid review.
Shanla,
Yes, ma'am.
hello.
Hello, ma'am.
Shanila,
Yes, ma'am. Parayu. Ma'am, Parayu.
hello.
Hello, ma'am. കേൾക്കുന്നുണ്ടോ?
Okay,
പറയൂ.
6:30 no?
6:30 ഉണ്ട്.
Start ചെയ്യാം.
സ്റ്റാർട്ട് ചെയ്യാൻ പോവാണ്.
ബാക്കിയുള്ളവർ ജോയിൻ ചെയ്തോളൂ.
അതെ. കേൾക്കുന്നില്ലേ? ഞാൻ പറയുന്നത് കേൾക്കുന്നില്ലേ?
ഹലോ
ഞാൻ പറയുന്നത് കേൾക്കുന്നില്ലേ?
കേക്കാം.
Okay. So, welcome to yet another series of rapid review in oral medicine and radiology for undergraduate students. It's hosted by Azizia College of Dental Sciences and Research, Kollam, in collaboration with Association of Stomatologists and Maxillofacial Imagologists of Kerala. So we have two eminent speakers for the day, that is Dr. Ashwati K. Vijayan and Dr. Joseph Johnny Appline. The first session is by Dr. Ashwati K. Vijayan. So I'd like to give a brief intro about Dr. Ashwati K. Vijayan. She is currently serving as an associate professor at PMS College of Dental Science and Research with over 9 years of dedicated teaching, clinical, and academic experience. She has completed her BDS from the Tamil Nadu Dr. MGR Medical University in 2008 and her MDS from KUHAS in 2016. And she has earned her PhD from Savita University. She has also been recognized as a PhD guide under KUHAS since 2022 and has contributed significantly to research with numerous national as well as international publications. She also serves as a CBCD in charge of a department at the college and plays a key role in advanced diagnostic imaging and clinical training. So welcoming Dr. Ashwati K. Vijayan over to this platform. And today's topic, she'll be speaking about fibroosseous lesions, paranasal sinus, and trauma imaging. Over to you, Dr. Ashwati K. Vijayan.
Okay, thank you, doctor. So shall I start now?
Yes, definitely you can start.
So good evening, one and all. Today, our session will be dealing with three important topics: fibroosseous lesions, paranasal sinus, and trauma imaging. So first, I will discuss the relevant questions that have been asked in the previous university. So from fibroosseous lesions, the essay question that was repeatedly asked in various university exam was classify fibroosseous lesions of the jaw and explain the clinical and radiographic features of fibrous dysplasia. It was repeatedly asked under KUHAS, Rajiv Gandhi, Amrita, MGR Medical University. Also as a short note and brief note, radiographic features of fibrous dysplasia, it was also repeatedly asked. And periapical osseous dysplasia, it was once or twice asked question as a short note. And coming to the sinus imaging, the question was enumerate various extraoral radiographic techniques used to image the maxillary sinus and write in detail the technique and indications of Waters' view, which was asked as an essay. And Waters' view again was asked as short note and brief note. And from trauma, it was like radiographic diagnosis of facial trauma once or twice, and it was asked under Health University. KUHAS, it was asked once or twice. So first we will start with fibroosseous lesions of jaw and the clinical and radiographic features of fibrous dysplasia. So fibroosseous lesions of jaw actually is a group of disorders. That means many lesions comes under this group of disorders. So it is defined as those lesions characterized by the replacement of normal bone by tissue composed of collagen fibers and fibroblast, and it again is get deposited by some mineralized substance. Here the normal bone is actually replaced, and in place of that bone fibrous tissue get deposited, and over time some deposition of bone or bone like material gets deposited. And because it is a group of disorder, the classification of fibroosseous lesions is always asked as a part of essay question. And there are various classifications of fibroosseous lesions by the WHO itself. So today I have included the latest classification in 2022. Here, the first and foremost one is fibrous dysplasia. Fibrous dysplasia is again divided into monostotic, polyostotic, and there is a craniofacial variety of fibrous dysplasia. Next is the cemento-osseous dysplasia group, which is again divided into periapical, focal, florid, familial gigantiform cementoma, and the newly added one is segmental odontomaxillary dysplasia. Next is the ossifying fibroma, that is a semomatoid ossifying fibroma and juvenile trabecular ossifying fibroma. Actually, ossifying fibroma is a neoplasm of this group. So this is the latest classification in 2022. If you are not able to classify this, you can write this classification. That is a Walrans classification, which is usually we deal this in the UG classes. That is fibrous dysplasia, cemento-osseous dysplasia, and fibro-osseous neoplasm. You can just write this classification during your examination. Here also there is fibrous dysplasia, the cemento-osseous dysplasia, only the periapical form, focal form and the florid form, and the neoplasm, you just write fibro-osseous neoplasm, that is a cementifying type, ossifying type, and the combined cemento-ossifying fibroma. Coming to the etiology of fibrous dysplasia, the fibrous dysplasia is caused by the mutation in GNAS1 gene. Even that sentence is, you can just write that sentence that for etiology, that is there's mutation in GNAS1 gene. And if you want to explain more about that, you can write because of the mutation in this gene, there is activation of adenyl cyclase. As a result, there is involvement in bone, there will be involvement of the endocrine system, and there is caffeolate spot. Anyway, in fibrous dysplasia, you know that there is involvement of bone. That is, a normal bone is getting displaced by fibrous tissue and amorphous bone-like material. Along with that change, there is endocrinal involvement. And also there is caffeolate spot, that is hyperpigmentations. And all this is because of the mutation of GNAS1 gene. And coming to the type, basically fibrous dysplasia is divided into monostotic and polyostotic type. As the name suggests, monostotic, it occurs only in one bone. Majority of the fibrous dysplasia cases are monostotic, and the males and female, it have equal predilection. Age is second decade of life. And the single bone itself, there are more chances to be occurring in rib than femur, tibia. Coming to the jawbone, more chances is for maxilla than the mandible. So that is with monostotic type, where a single bone is involved. And for us, it is a maxilla more than that of mandible. And there is no gender predilection. Males and females are equally affected. Majority of the case in comparison with polyostotic is monostotic type of fibrous dysplasia. Coming to polyostotic type of fibrous dysplasia, as the name suggests, it is polyostotic. That means it is involvement of two or more bonds. And here comes the etiology that we have already dealt. Other than the involvement of bonds in etiology, we learned that there is endocrinal involvement and also hyperpigmentations because of the hyperactivity of melanocytes. That means polyostotic fibrous dysplasia has got two other varieties like Lichtenstein-Jaffé type and Albright syndrome. Lichtenstein-Jaffé type means polyostotic fibrous dysplasia, that is bone involvement with caffeolate spots, that is hyperpigmentation. Albright syndrome means there is polyostotic fibrous dysplasia along with both hyperpigmentation and precocious puberty or other endocrinopathies. Because the endocrinal problems are there, polyostotic fibrous dysplasia, there is a chance to occur more in females. And compared to monostotic fibrous dysplasia, it occurs in a younger age. Polyostotic type of fibrous dysplasia, and the bones are skull, even facial bones, pelvis, spine, and shoulder girdle. Even this Albright syndrome itself is asked as a short note question. Clinical features of fibrous dysplasia, as we discussed, most commonly area is maxilla, followed by mandible, and the bones like frontal, sphenoid, ethmoidal bones, occipital bone, and temporal bone. Mandibular lesions are truly monostotic. That means if mandible is involved, it is truly only mandible. But if maxilla is getting involved, this lesion has a tendency to involve the adjacent bones like the zygoma, the sphenoid, and occiput. That means truly if it is not monostotic, it is getting into polyostotic, or it is a craniofacial variety of this type. Usually fibrous dysplasia, there is a painless swelling. There is a swelling of the affected area, especially the maxillary posterior region. It is unilateral in the maxillary posterior aspect. Patient reports to you with the swelling, but it is not painless. And if it is expanding, if it is getting expanding, expansile lesion, it will cause a displacement and tipping of the teeth. And now when we examine clinically the maxillary posterior region, we can see the mucosa is intact. And as already I told, it has got an tendency to involve the other nearby bones, especially the maxillary antrum and the nasal cavity. So monostotic type of fibrous dysplasia is more common than polyostotic type. It is usually seen in the maxillary posterior unilateral. It is not that much expansile, and if it is getting expanding, it goes into the nearby regions like the maxillary antrum, sinus, maxillary sinus, and the nasal bone, and it causes tipping and displacement of the teeth. Radiographic feature is itself an important short note, brief note question. Whenever a question is asked as radiographic feature, not only for this question, any other question, try to answer in the heading like location, periphery, internal structure, effects on the surrounding structure, and the adjacent teeth. Any question, if you're supposed to, for example, radiographic features of osteomyelitis, Paget's disease, any question, write under this heading. Coming to our fibrous dysplasia. Suppose the question is fibrous dysplasia, radiographic feature, a 3-mark question. Start with what is fibrous dysplasia and go directly to the radiographic feature. Location. Where is the location? It is seen in the maxilla twice as often than the mandible. Where in maxilla? It is in the posterior aspect. It is unilateral. What about the periphery? Periphery means how you see this lesion in an X-ray, how if it is ill-defined or well-defined. The periphery of fibrous dysplasia is ill-defined. That means you cannot trace the periphery as such. You cannot draw around the lesion in an X-ray. That means the lesion is smoothly blending with the surrounding trabecular pattern, trabeculations. It's just smoothly blend with the surrounding trabeculations. So you cannot tell, okay, this is a boundary. No. Periphery is ill-defined. Always you can tell periphery is well or ill. For fibrous dysplasia, it is ill-defined. Internal structure. How can you see the lesion in an X-ray internally? All fibroosseous lesions, majority of fibroosseous lesions go through 3 stages. A lytic stage, a mixed stage, and a radiopaque stage. Why these 3 stages? You just go back to the etiology and the definition. Here, the normal bone is replaced by fibrous tissue, and then the deposition of bone occurs and it matures. And if the patient comes at you at an early stage and if you take an X-ray, the lesion appears as radiolucent. And if time goes, it appears as radiolucent, radiopaque. That is your mixed radiopaque, radiolucent lesion. And if it is getting matured, it is radioopaque. So for all lesions, fibroosseous lesions, you can write these 3 stages. Internal structure, I will deal little more in the next slide. Effects on surrounding structure and teeth. Already we discussed that this is an expansile, some bit expansile lesion, and it expands along the length. That means majority of the tumors, it expands around. That is, it has a concentric growth. That is why we are calling it as expansile lesions. But some lesions is like it grow within the bone. That is, it has got a fusiform growth. And this fusiform growth, it is because of this growth, we are not seeing that much expansion clinically. And this lesion, this fibrous dysplasia has got a fusiform growth pattern, and it grows and it goes to the nearby maxillary sinus, and it affects the lateral wall of maxillary sinus first. And even if it gets into the maxillary sinus, the walls of the maxillary sinus are not affected. The whole shape is not actually affected. The size of the maxillary sinus will get reduced, but the walls remains intact. That is very particular about fibrous dysplasia. The walls of maxillary sinus remains as such. It affects the lateral wall first, and the last wall to get affected is the posterior-superior wall. The size reduces, but you can trace even the walls, the cortical bone, the floor even remains as such. If it is in the mandibular posterior, the nearby landmark is inferior alveolar nerve canal. It displaces the inferior alveolar nerve canal in a superior direction. That is the effect on surrounding structure. One is the fusiform growth, the involvement into the maxillary sinus, lateral walls, posterior-superior wall is the last to get affected. And even though the sinus is affected, the walls are not, we can trace the walls, but size, the lesion effect gets into the sinus. Inferior nerve canal is displaced superiorly. And what about our teeth? There will be loss of lamina dura and displacement of teeth. So this is a radiographic feature of fibrous dysplasia. Coming to the internal structure, there are various appearances for fibrous dysplasia. One, it is radiolucent. The early stage, it is completely radiolucent. There is nothing inside. But when it comes into a mixed stage, there is ground glass appearance, a granular appearance, or we call it as a sandblasted appearance. And other appearance is known as orange peel appearance. Getting little more matured, it is cotton wool and fingerprint appearance. So if radiographic feature is asked, in the internal structure, you have to include these appearance also: ground glass, orange peel, cotton wool, and fingerprint appearance. This is because the lesion has got a mixed stage where there is radiolucent and radiopaque areas can be seen in an X-ray. Differential diagnosis, if it is a 3-mark question, no need to write the differential diagnosis. But if it is a 5-mark question, you can add the differential diagnosis. That is the lesion that mimics like a fibrous dysplasia in an X-ray. Hyperparathyroidism, Paget's disease, osteomyelitis, osteogenic sarcoma, and ossifying fibroma. Usually in the undergraduate level, the name is okay. But anyway, you may learn these in differential diagnosis of lesions in like mixed lesions, periapical radiolucencies. You have to learn how to differentiate one from the other. Hyperparathyroidism, usually it is polyostotic. Why we include this in our differential diagnosis? Because hyperparathyroidism also, has got a ground glass appearance. But it is mainly polyostotic and there is no expansion seen in hyperparathyroidism. What about Paget's disease? The typical radiographic appearance of Paget's disease is cotton wool appearance. But Paget's disease, it's polyostotic and it's an expansile lesion. Osteomyelitis, yet another mixed lesion. But osteomyelitis, people will know that because of the formation of cecustrum and involucrum, the bone formation, the mixed radiopaque bone formation is seen outside of the lesion. But our fibrous dysplasia has a tendency, the bone deposition is from inside outside. It starts from the internal aspect, the bone deposition, it starts growing, moving out. Osteogenic sarcoma, it is of course a malignant neoplasm. It has got all the changes, aggressive nature of sarcoma. Ossifying fibroma, it is also a neoplasm and it has got a concentric growth. That means it moves outward, not like our fibrous dysplasia that goes into the bone. So that is the differential diagnosis. At least you can name the lesions, even though you are not trying to explain it. Coming to the treatment, orthodontic treatment and cosmetic surgery after skeletal maturation. So that is, you have to write when you're asked about an essay on classify fibroosseous lesions, any one classification, and discuss in detail about the clinical features, types, etiology, and radiographic appearances of fibrous dysplasia. I think you will get more through this pictorial representation. So here in this picture, you can see there is a swelling, a small swelling where the skin is so much intact in the posterior maxilla. And here, this is what I told, the ground glass appearance, a granular appearance. And this is a cotton wool appearance. See the difference in the mixed stage itself. This is early stage and more radiopacity is seen here. That is a cotton wool appearance. And in this picture, can you appreciate that this is a maxillary sinus? In this image, CPCT image, here this is a maxillary sinus. See, the lesion is getting expanded. It moves into the nearby maxillary antrum. It involves the lateral wall, but still the walls are all intact. The size of sinus getting decreased, reduced, but you can trace the walls of the sinus. And here you can see the inferior alveolar nerve getting displaced in, this is the inferior alveolar nerve canal, and the lesion getting its displaced superiorly. So this is the pictorial representation of what we have discussed in theory right now. Moving to the second question of the day, PCOD or periapical osseous dysplasia. Once or twice this was asked as a 3-mark question. Again, PCOD is a type of fibro-osseous lesion. And you now knew the etiology of fibro-osseous lesion where the normal bone undergoes some changes. There's resorption of the normal bone and the bone is removed and it is replaced with fibrous tissue. Not only fibrous tissue, some amorphous bone or a mixture of both of this. Here PCOD also has the same etiopathogenesis. Clinical feature, PCOD is usually seen in middle age, 30 to 40 years and mean age of 39 years. It is seen 9 times more in females and black females. And the teeth is vital. That means a patient never comes to you with a complaint of PCOD or symptomatic patient won't come to you. This is an incidental finding, especially we take an OPG for an orthodontic purpose and we will see the lesions. There is notable expansion. So clinical features, it is seen in the middle age, in the black females, and where it is seen in the periapical region. It, as the name suggests, PCOD, periapical osseous dysplasia. It is seen in the periapical region of mandibular incisors. Most commonly, it is seen in the periapical region of mandibular incisors, and the teeth always remain vital. Radiographic features, again, location, periphery, internal structure, effect on surrounding structure. Where is the location? Periapical region of mandibular anteriors. Periphery, in contrast to fibrous dysplasia, it is well defined. Periapical osseous dysplasia has a well-defined periphery. That means you just imagine that the initial stage is radiolucent. Now the bones start getting deposited and from inside it moves outward. And finally, at the end, there is a small radiolucent border. That is the radiolucent border we see in osseous dysplasia. And as a defense mechanism of this pathology, the surrounding bone gets deposited more. So the whole thing is again surrounded by a sclerotic region. That is the periphery. So well-defined lesion with a sclerotic border. Internal structure, because it has got a lytic stage, radiolucent, a mixed stage, radiolucent, radiopaque, and a mature stage that is radioopaque. Effect on surrounding structure, as it is attached to the periapical region of the teeth, there is loss of lamina dura and larger lesions might cause expansion. That is a radiographic feature. Again, differential diagnosis, not mandatory to write, but even if it is a 5-mark question, you can write, at least you can mention the name. The differential diagnosis is periapical rarefying osteitis. Periapical rarefying osteitis is always a pulpal pathology. and the tooth will be non-whitened. Ossifying fibroma, what I explained in the previous slides, ossifying fibroma is a neoplasm. The growth is concentric. Periapical dysplasia, it is not that much of concentric growth. Chronic osteomyelitis, again, the bone deposition is on the outside aspect, sequestrum, involucrum, etc. But our periapical osseous dysplasia, the deposition of bone is from inside out. Ossifying fibroma, again, the neoplasm, concentric or expansile growth. Benign cementoblastoma, usually cementoblastoma is usually seen in the molar region, mandibular molar region, and it is usually attached more to the root surface, not at the periapical region. It is attached to the more to the root surface. Condensing osteitis, it is also sequelae of caries. You have a wide-seated restoration or a deep dentinal caries in condensing osteitis. Odontoma, tooth-like structures will be seen. It is easy for you to differentiate. Even dense bone island is actually periapical sclerosis, idiopathic periapical sclerosis, which is seen in the bone. It doesn't have any well-defined capsule around it, so you can differentiate it from periapical osseous dysplasia. At least you write the name: periapical, rarefying osteitis, ossifying fibroma, chronic osteomyelitis. Any of these fibroosseous lesions asked, you can write this chronic osteomyelitis, ossifying fibroma, etc. Because all these have 3 stages. You can write all these lesions. Management, not normally required unless and until it is secondarily infected. So here this is a lesion. Stage 1, it is attached to the root end. Mandibular incisors are commonly affected. Stage 2, see, radiopacities from the middle aspect. It moves outside. So you can see a radiolucent border here. And this is a stage, initial stage, a mixed stage, and a more radio-opaque stage. So that is with osseous dysplasia. Coming to the second session of the day, imaging of paranasal sinus. Already this portion is discussed along with extraoral radiographs. Imaging of paranasal sinus questions means as such imaging of paranasal sinus was asked once. Imaging of maxillary sinus was asked, but the most common question is Waters view. Majority repeatedly asked question is Waters view. But in maxillary sinus, intraoral view, you know that IOPA, intraoral IOPA, posterior teeth IOPA, you will get the sinus floor and the base. Same with lateral maxillary occlusal. Extraoral view, the common one is OPG. And already in the extraoral radiographs, sir has discussed that PA sinus view, standard occipitomental projection, modified occipitomental projection, Brekma-Menton, and the most common one is Waters view. So these bold one, that is standard occipitomental, modified, Brekma, Waters view. Of course, PA sinus view. Frontal sinus, again Waters view, PA sinus view. Sphenoidal sinus, Waters view, open mouth. PA sinus view is common for all sinuses. Ethmoidal sinus also, Waters view and PA sinus view. These are the common views. So we will just brush up with the views already taken class. In PA sinus, which whenever you are asked to write the views, you should write in 4 headings. Now, first, the placement of the receptor, patient positioning, the central ray, and indication. So this is a PA sinus view, and here the receptor is placed vertically perpendicular to the floor. Vertically perpendicular to the floor. The patient is positioned in a way that the head and the nose, forehead and the nose touches the cassette. That is, the sagittal plane is vertical and perpendicular to the cassette. The central ray moves through the cantomeatal line. Indication is for sinuses. Standard occipitomental or 0-degree mental view. Here the cassette is again placed vertical, that is perpendicular to the floor. The patient is positioned in a way that the nose and the chin touches a cassette. And this position of the patient makes the canthomeatal line at a 45 degree to the receptor. This radiographic baseline at 45 degree to the cassette. And the central ray is through the mid of the skull. Indication is for all sinuses, even maxillary sinus. Modified occipitomental view. Again, all positions same as that of standard. The receptor is placed in a vertical plane, perpendicular to the floor. The patient positioning is in a way that the nose and the chin touches the cassette. The sagittal plane is placed vertical, perpendicular to the cassette. And the central ray is at 30 degree as it passes through the lower border of the orbit. See, the central ray is like as it passes through lower border of the orbit. Again, because of this position, the canthomeatal line is at 45 degree to the cassette. Same positioning for standard occipitomental and modified occipitomental, only change is the passing of the central ray. And both these methods, indication is for maxillary sinus. Brecma mental, as the name suggests, the central ray is through the brecma region to the mental region. Now here there's some difference. The cassette is placed parallel to the floor. In a cassette holding device or any table, it is placed parallel to the floor and patient is asked to rest the chin over the cassette. That is, the chin or the lower border, chin should be protruded little. That means the lower border should be, the chin should be parallel to the floor. The canthomeatal line is also parallel to the receptor. Once the patient is placed like this, the central ray moves through the brecma region to the mental region. So these are, apart from the Waters view, these are the four maxillary sinus views. You can write if the question is maxillary sinus view, but usually the maxillary sinus views like enumerate the technique. You just need to write the techniques. No need to describe each and every technique because they are asking to describe Waters view. Why I included this slide is, in Waters view, in views, different areas of maxillary sinuses are seen. For example, in periapical X-ray, the floor and base is seen. In OPG, which we are widely using, we are appreciating the posterior and the medial wall. You just write posterior and medial wall. In Waters view, it is a lateral and medial wall. See, all walls and floors might be seen, but which can be seen that the best we are describing here. In Waters view, the antral cavity can be seen, but the lateral wall and the medial wall. In the lateral skull view, the anterior and the posterior wall is seen. And CT, which is a 3D imaging modality, you can see all and around, all floor and all the walls of the sinus you can see. So this you can just mention which all areas in each views can be seen, well-defined areas you can see. Coming to the second part of the question, that is Waters view. So Waters view, the first heading is film placement. How the film is placed? The film is placed in vertically in its plane, perpendicular to the floor. How the patient is positioned? The patient is positioned in a way that the chin touches a receptor and the nose tip is away from the receptor. Because the patient is positioned in such a way, the canthomeatal line is at 37 degree to the canthus, to the film. That is, the canthomeatal line is at 37 degree to the film receptor. The central ray, it is passing through to the center of the film. Indications, we can see the frontal sinus, blue shaded ethmoidal sinus, the green shaded maxillary sinus, and if it is an open mouth, we can see the sphenoidal sinus. So indication is the frontal sinus, ethmoidal sinus, maxillary sinus, and open Waters view will give the sphenoid sinus. So that is a classification of maxillary sinus view and Waters view, the indications and technique of Waters view. If Waters view itself is asked a 3-mark question, this is enough. You just write the placement of film, patient positioning, central ray indications. But if it is a 5-mark question, because it is asked majority times as a 5-mark question also. Apart from this, you can add what all you look in a Waters view. Why you're taking a Waters view? It is to view the maxillary sinus. You know that maxillary sinus, a healthy maxillary sinus is always radiolucent because it is an air-filled cavity and it is associated with the maxillary bone. All sinuses is associated with its particular bone and it is radiolucent because it is air-filled cavity. But when a lesion or any pathology comes, it changes its appearance into radio opacity, or we can call it as haziness or opacification of the sinus. Now, if it is as a 5-mark question, you can add a note on the differential diagnosis of lesions in maxillary sinus. Just add the name only. That is, mucositis can be seen in maxillary sinus as radiopaque band. Sinusitis, because it is fluid-filled cavity, there will be increased radio opacity. Retention pseudocyst, it is a dome-shaped mass. Polyp, majority of cases we can see while taking 3D images, majority of the patients do have this mucositis and polyps. It appears as radiopaque, that is thickened mucous membrane. Anthrolith, it is that much radiopaque. Mucocele, it is seen within the sinus, but it is a bit destructile lesion. Malignancy, there is severe erosions of the walls of the sinus. Just add, if it is a 5-mark question, along with the Waters view, the technique, you can just add, these are all the conditions we take a Waters view to evaluate the maxillary sinus. Coming to the third topic of the day, imaging of facial trauma. Imaging of facial trauma, usually it was asked only once or twice and it was like a 5-mark question. I didn't see any essay part for this question and no other universities I had seen this question. But in Health University, twice it was asked as a 5-mark question. Not recently, it was asked as a 5-mark question. So imaging of facial trauma, just divide it into 3 topics: dentoalveolar fractures, mandibular fractures, and maxillofacial fractures. Before going into the topic, understand that this fracture, actually we consider always fracture as a line, but fracture actually has got a 3-dimensional view itself. But in a 2D imaging technique, always it is considered as a line. And how do this fracture appears in an X-ray? What is the basic principle? Any fracture appears in different views because of the principle that it depends upon the angulation of the X-ray beam to the fracture line and the amount of separation of the fracture segments. How you are angulating your X-ray beam to that particular fracture line and how much the fracture segments are separated. Because of this, there are different appearances of fracture line. See, here the X-ray beam is parallel to the fracture line and there is only a single fracture line. Here X-ray beam is at angled position and there is double fracture line. Here sometimes one fracture segment overlap over the other and we might not get like radiolucencies as we always see. Here it appears as radiopaque because one is getting overlap over the other segment. And if it is perpendicular, if the X-ray beam is perpendicular to the fracture line, we are going to miss the fracture line. We are not going to see the fracture line. So this is a principle of a fracture line appearing in a 2D imaging. So coming to the first topic, dental fracture, you just write what are all the fractures like infarction, crown infarction where the enamel is lost a bit. Then there is crown fracture, complicated and uncomplicated fracture. Then crown root fracture, root fractures and periodontal tissue injury. These are the type of dental fractures. Any fractures, the basic assessment is an intraoral periapical radiographs. And you just write which all appearances these X-rays gives us. As we discussed in the previous slide, as a single line, as 2 lines, has an haziness, has a radio opacity, and all this depends upon the angulation of X-ray beam to the fracture and the separation of the fracture. Majority of the non-displaced fractures we cannot see initially. We can just see as a widening of the PDL ligament space. But as time goes only, this separation we can see. For example, in a non-displaced horizontal fracture, root fracture, we cannot see if it is non-displaced. But as time goes, there will be inflammation of the periodontal ligament and the separation we can see. Even this is the same case with vertical root fracture. And in periodontal tissue injuries like concussion, then intrusion, extrusion, avulsion, here also there are subtle changes with the periodontal ligament. That is widening of the periodontal ligament if it is a concussion. And sometimes if it is an intrusion, there is obliteration of the periodontal ligament space. And if it is an extrusion, there is a more area of periodontal ligament space. And if if it is an avulsion, what happens? There is only the lamina dura you can trace. So this, for the PPT, I have added that. Coming slides, we will discuss in which all fractures, which view we will take. So in extraoral view, you can just mention these two lines, Dolenz lines and McGregor lines. As you know that for OPG, we have different zones. Here also in Dolenz line, this is to evaluate the fracture. See, this is the orbital line. Here you have the zygomatic line over the zygomatic arch, and this is a maxillary line. You just mentioned the orbital line, the zygomatic line, and the maxillary line. McGregor line, the first line here through the zygomatico-frontal suture. The second line is through the zygomatic arch over the infraorbital region to the nasal part. Third line, the fracture to evaluate in the coronoid process, condylar head, to the opposite side. The fourth one is if there is any fracture of the occlusal aspect of the maxillary and mandibular region. And the fifth is the inferior border of the mandible. Just if this question comes, you just add this name, Dolenz line and McGregor lines for an extraoral view, especially in Waters view. Mandibular fracture, actually it is divided into fractures of symphysis, body, the ankle fracture and ramus fracture, then the coronoid fracture and condylar head fracture. Other classification is of the type like symbol fracture, then comminuted fracture, green streak fracture, if it is an incomplete fracture involving only one cortical plate. Then you have pathological fracture if there is a cyst and there's after that or a tumor, there is a fracture, it is a pathologic factor. That is based on the location, you have a classification based on the types. Then you have favorable and unfavorable fracture. Favorable fracture means the muscle pull will not displace. The fracture segments will come near each other. The other one means unfavorable means the muscle will displace the two fracture segment. That is favorable and unfavorable fracture. So mandibular fracture, the most common area is the condylar neck. Whenever there's a condylar neck fracture, there will be associated body and head fracture, and the head gets displaced anteriorly, medially or inferiorly. And the common view is the lateral oblique view, where mandibular fractures, body, symphysis, ramus, the view is lateral oblique. Also lateral skull and PA skull view will go for mandibular fracture. The orbital blowout fracture, this is a CT image, and here you can see the orbital fracture. And the most common area that affects is the floor of the orbit and also the medial aspect of the orbit. So this is a floor and the orbit, and here you can just add two names. That is trapdoor appearance, that is a fracture, this red arrow, the fracture of the orbital floor. And because of this fracture, the orbital contents comes into the sinus, and that is a teardrop sign. And thus, usually the views are standard occipitomental view, Calvel view, and the lateral skull. Orbital blowout fractures, just add the name trapdoor and teardrop sign and add which side is going to get fractured. That is a floor and medial wall. Medial wall of the orbit is a ethmoid bone. Zygomatic fracture, the view is submentovertex view and the modified view. Add a note on tripod fractures in zygomatic fractures. That is, include the zygomatic arch, the orbit, the frontozygomatic suture, and the maxilla, the zygomatic maxillary suture. You will just add the tripod fracture that involves the zygomatic bone, the orbit, and the maxilla. And Leaford fracture, the view is standard occipitomental, 30-degree occipitomental view, and the lateral skull view. The same view we discussed for maxillary sinus. It can be used for Leaford 1, 2, 3 fractures, even the condylar fractures, orbital fractures, all we can use the same views. Lefort 1 fracture, it is a displacement of the tooth from the maxilla. Lefort 2, it is a pyramidal fracture where the midface is separated from the skull. It moves from the nose tip, it moves inferiorly and laterally down to the sinus and to the pterygoid region. Lefort 3, it is craniofacial disjunction, that is a midface is moved away from the cranium. It is actually an extensive form of the Lefort 2 fracture. Here you can see it moves little more anteriorly and superiorly. That means it is getting involved is a zygomatico-frontal suture. So just write Lefort 1, 2, 3, the views, and just mention what is Lefort 1, tooth from the maxilla, Lefort 2, pyramidal fracture, midface from the skull, and Lefort 3, it is an extensive fracture. The whole midface is removed from the cranium. So that is the last slide of the day. So the topic, fibroosseous lesions, sinus imaging and fracture. Fibroosseous lesion classification, you have to learn before going for the exam. Any one classification, learn about fibrous dysplasia, the radiographic feature in detail. PCOD also you have to learn. Sinus imaging, just learn the views for the sinus and in detail about Waters view and in which all conditions we are going to take the Waters view. Fracture, just write which all types of fracture is there, how do a fracture line appears, and in orbit, zygomatic, Lefort, which all areas are getting affected first, and which are the views we are taking each for these fractures. So I think I will conclude with that. Thank you. Thank you, everyone.
Thank you so much, Dr. Ashwati. It was an elaborate session, and though it, it's a vast topic as such, you've concised it so well and we've explained it so well to the delegates. I hope one and all has understood this topic. If you have any queries, you may ask your questions. You can raise your questions in the chat box itself because we have another session upline. Thank you so much, Dr. Ashwati. Please hold on to this session. At the end of the session, we will definitely go back to the Q&A session with the delegates. Okay. Thank you so much, Dr. Ashwati.
Yes, Doctor.
Dr. Joseph Johnny, you're there?
Yeah. Am I audible?
Yes, you're audible. Can you please share your screen? Before we move on to this next session, I would like to warmly extend my warm welcome to Dr. Joseph Johnny. He is presently working as a professor and head of the Department of Oral Medicine and Radiology in Sri Anjaneyar Institute of Dental Sciences, Olieri, Kozhikode. To give a brief intro about Dr. Joseph Johnny, he has done his BDS from Amrita School of Dentistry in the year 2009. Followed by his Masters of Dental Surgery in Oral Medicine and Radiology from Mar Basilius Dental College, Konamangalam in 2015. He's also attained his fellowship in training program in regenerative medicine from Toronto University in Canada, and he has a lot of numerous national as well as international publications in hold. And over to you, Dr. Joseph Johnny.
Thank you, Dr. Shanle, for the wonderful introduction. And also thank you, Dr. Ashwati, for the wonderful session. Okay, so moving to my session. So today's topic is oral potentially malignant disorders and oral cancer. So as you all know, oral potentially malignant disorders is a very important topic. So the most important question is define oral potentially malignant disorders and write in detail about either OSMF or lichen planus or leukoplakia. I would say finally a part 1 student cannot go for an oral medicine exam without studying these 3 things, that is leukoplakia, lichen planus and oral submucous fibrosis, because 60 to 70% of question papers have any one of this. So one question from this is almost kind of a sure shot for your university exam. Apart from that, I've also added few more questions which I got from few question papers, and few have added new questions also, because if you see the current trend in KUHAS, every year they are adding some 2 or 3 questions, new questions. Okay, So these are the questions which we're going to discuss. And again, to the final year part one students, just 3 points which I want to tell you. One is, whenever you're writing an essay question, please try to write the contents. Please leave the first page for just for writing the contents. That is point number one. Second point is, when you're writing an essay, at the end of the essay, if you can just mention the reference, it is very nice. It is very impressive. You can write which textbook you took it, which edition, it would be very nice. And third thing is that when you're writing an essay, please give a stipulated time for essay, because most of the time students spend a lot of time writing only the essay, and they don't get time for the short essays and short notes. So please keep all these things in your mind. So coming on to the session, so our first thing definitely is the definition. So I have given you the definition. So for oral potentially malignant disorder, it's an abnormality that is associated with statistically increased risk of developing oral cancer. I've also put the definitions for pre-malignant lesion and condition, mainly because still few question papers I could see that question as pre-malignant lesion. So this is the definition, which is a morphologically altered tissue in which oral cancer is most likely to occur compared to the normal counterpart, and pre-malignant condition, which is a generalized condition. But actually, in the year 2007, 2005, actually, the WHO has summed both this terminologies, pre-malignant lesion and pre-malignant condition, into a single term, that is oral potentially malignant disorders. So these are the list of oral potentially malignant disorders: leukoplakia, erythroplakia, lichen planus, it goes on like that. So you have studied all these things, and these were few other which were added to the previous list. I've also put the pre-malignant lesions and conditions table also, because as I told, some question papers still they are asking pre-malignant lesion and condition. So these are the basically, if you add both the pre-malignant lesion condition, what we get is the oral potentially malignant disorders. So coming on to the first and the most important pathology, that is leukoplakia. Leuko means white, plakia means plaque. There are many definitions for leukoplakia, but definitely go for the latest definition that is given by Pinbor. There's a predominantly white lesion which cannot be characterized as any other definable lesion. So that is the definition. There ends the definition. Next is the etiology. As you all know, etiology, there are a lot of etiological factors, in which one is tobacco, second is alcohol. Tobacco, you can just put some 2 or 3 sentences on tobacco. That is, there are smokable and smokeless tobacco. It contains about 300 carcinogens, N-nitrosin or nicotine, and nitropyridine. So there are 300 carcinogens. You can just put a word. Alcohol is another one important question. Alcohol is another one etiology where you can put 2 or 3 sentences on alcohol, like it causes dehydration, so easy penetration of the carcinogens. You can also write alcohol has got a synergistic effect with tobacco. Viral infection, yes, again a very important etiology, where we can see a lot of cases we get where the human papilloma virus is etiology. Leukoplakia in diabetes, again there is 3 times the chance is more. Candida leukoplakia or Candida associated with leukoplakia is again one important etiology. Dietary factors, if there are deficiency in certain vitamins. And again, sharp cusp, that is sharp cusp, when it becomes too much traumatic, constant trauma can also lead to oral leukoplakia. So yeah. So next thing is that you need to write about the clinical features. So when you go in the essay, and the contents also, first comes the definition, next comes the etiology, next goes to the clinical features. Clinical features, it is mandatory that you should mention what is the age group in which it is seen, and again, with gender, it is more predominant. So this is the details. So 25 to 55, male is very high predominance. Next, these 2 things you should make sure that you've written in the clinical features. One is the types, what are the types of leukoplakia? And the second is the staging of the leukoplakia, very important, right? So types, in fact, I think different textbooks are having different classification. You can write whichever classification you are comfortable. This is one classification, pre-leukoplakia, homogeneous and non-homogeneous. Homogeneous means it will be having a flat uniform texture, and non-homogeneous, where we have this erythroleukoplakia, speckled, verrucous, and proliferative verrucous leukoplakia. Proliferative verrucous leukoplakia is still in a debatable condition whether it has to be added into leukoplakia, because most important etiology is found to be human papillomavirus. But if you're writing in the types also, it is not a big problem. Okay, so proliferative verrucous leukoplakia. This is another classification by Axel et al. In the year 1984, and it is tobacco associated, based on the etiology, tobacco associated idiopathic, and clinically homogeneous and non-homogeneous. Where in non-homogeneous, we have the erosive, nodular, and verrucous. This is another classification by Bokot and Whittaker, where basically it's all the three classifications are similar only, but with just a little bit of difference in the arrangement. That's it. We have phase 1 where we have the pre-leukoplakia, phase 2 where we have the homogeneous, phase 3 where we have the nodular or granular, phase 4 we have got the specular non-homogeneous. Okay, so where we have the erythroleukoplakia, candida leukoplakia, and things like that. Okay, so coming on to staging. Actually, most of the textbooks which we can see, it is only L and P is given in the staging. But in the year 2005, in fact, Vanderbilt has also introduced S and C. So please note this down because L and P is mostly, most of the textbook it is only L and P, and the staging is also given according to this L and P. So please understand there is an additional S and C also. S is actually the site. So S1 is basically all of the sites except the floor of the mouth and the tongue. And S2 is where we have it in the floor of the mouth and the tongue. And C is whether it is homogeneous or non-homogeneous. So C1 is homogeneous and C2 is non-homogeneous. So based on that, we have got the staging also. This thing you have to by heart, it is mandatory. So this is a very important thing which you need to write in the clinical features. And I would tell when you're writing an oral medicine answer, please make it a point that you at least give 2 differential diagnoses for this condition. And again, you're giving 2 points by which you can differentiate it from the current condition. So one is chronic hyperplastic candidiasis, which we can say that it is commonly seen in immunocompromised patient. In leukoplakia, we can say it is associated with the use of tobacco. And chronic hyperplastic candidiasis, you give a fungal medication in response to it. So next one is plaque type lichen planus, which is like more very similar to leukoplakia, but it can be differentiated based on the fact that lichen planus is very commonly seen in it has a bilateral occurrence, and tobacco has got more of a unilateral, or where more of the tobacco smoke is coming in contact. So write at least 2 differential diagnoses for any condition which you get for an essay. Coming on to the diagnosis part, vital staining is a very important question. It was asked once in KUHAS. So it was in vital staining which was asked. The question was toluidine blue staining. So vital staining, in fact, toluidine blue staining is actually, we do staining of the vital or the living tissue. Basically what we do, this is mainly for, in a screening purpose, or if you're going for a biopsy, you need to know where more is the dysplastic changes. So you'll go for this staining technique, which will help you a little more accurate diagnosis. So toluidine blue is actually a acidophilic dye. Acidophilic means loving. So basically, when you have a dysplasia, which is one feature of leukoplakia, you will have increased amount of mitosis, more amount of nucleic acid, more of an acidic this thing. So more this toluidine blue can get attached to the dysplastic cells. So that is the basic mechanism. So leukocidin is again another one important vital staining technique, but here the technique is different. Toluidine blue, if it was the dysplastic cells getting stained, here it is mainly the normal cells getting stained. So what happens is potassium iodide is used. So potassium iodide is having more of like a affinity to glycogen. So this glycogen will be less present when there is keratinization. So keratinization is a feature of leukoplakia. So leaving the abnormal dysplastic cells, it will stain the normal cells. So basically people do both together. So you get a better result. Biopsy, another one very important question. Biopsy, if you're getting a question on biopsy, what you should write? Just 2 things. One is, what all are the indications of biopsy? And second thing, what are the types of biopsy? Just that's it. No need to write anything else. This finishes the answer. So the wording meaning of biopsy is bio means life and opsy means to see. So you're basically seeing life through cells. So basically in biopsy indications, you can say to rule out the malignancy, to say like it was not responding to treatment, or if the lesion was very large, you want to know the exact nature of what is the lesion. So all those things you can write in the indication part, and in the types you can write incision biopsy, excision biopsy, punch biopsy, brush biopsy, and FNAC. So these are the different types of techniques. So that ends the answer to the question biopsy. Fine. So as I told histology, I would say like when you're writing an oral medicine, don't give too much of importance for the histopathology because we are mainly focusing on the clinical features. But still, in a case in leukoplakia, the most important histopathological features are one is hyperkeratosis and the other one is the features of dysplasia. Okay, dysplasia. What is the meaning of dysplasia? Dysplasia means abnormal change. So this is one video presentation. I'll just rush fast. So basically in dysplasia, the cell size is increasing, and you can also see that there is increase in the size of nucleus. The cell size is increasing. You can see the nucleus size is also increasing, and there is abnormal mitosis. There is change in the shape of the cells. There is abnormal division. So basically, the retiridges will have more of like a blunt shape. Okay, bulbous retiridges, called bulbous retiridges. And when there's abnormal cells, when they are just breaking the basement cells and basement membrane, if they are invading into the connective tissue, that is what we call malignant or squamous cell carcinoma that we all know. And in the same way, there is something called as loss of polarity. So basically, in a normal epithelial cell, the stratum basale is more division is happening there. So basically, the keratinocyte differentiate from there, go up to the different layers, and it is finally going out as keratinocyte. So, but in case of dysplasia, what happens is this normal pattern of how the keratinocyte migrates is gone. Here you can see the keratinocyte, the epithelial cells or abnormal epithelial cells are going in zigzag fashion. That is what we call loss of polarity. Some gets trapped inside the epithelial cells also, and that is what we call dyskeratosis. And we have multiple what you call the trapped cells. We will have something called as what you all hear keratin pearl. So these are some of the features of dysplasia. So you just need to write out the features of dysplasia. So this is a keratin pearl. So you need to write about the features of dysplasia and keratinization. That is what you need to write on the histopath. Now coming under management, you can you know all these things. I just going a little fast. You need to stop the habits. You can also advise go for the 5 A's. You can go for pharmacological replacement, bupropion, varenicline. These are certain drugs which you give. And antifungal. Antifungal is the first line of treatment. You can also go for topical corticosteroids. Not corticosteroids, topical antioxidants, carotenoids, beta carotene, retinoic, phenretinine, vitamin C, lycopene, etc. So see, okay, topical chemotherapeutic drugs can also be given. Another one is photodynamic therapy. Photodynamic therapy also can be asked as a bouncer question. So I have put photodynamic therapy also a small this thing. In photodynamic, where we are basically injecting a photosensitive dye, like for example aminolevulinic acid, porphyrins, etc. So what happens is it will go selective and it will be taken by the lesion. And when you are just flooding it with a particular wavelength, what happens is there are formation of reactive oxygen species, free radicals, and thereby it is destroying damaging the cancer cell. That is the basic mechanism of photodynamics. So if you get a question of photodynamic therapy also, please be informed. This is the answer. Okay. So this is a classification of, not classification, this is a flowchart on how a leukoplakia is managed. This is from Ravikar and Ongol, but you can use it, but you can just write what you study in whichever text you are studying also. Here, basically, first we go for antifungal, we look for the response. If it is responding, well and good. And if it is not responding, less than 1 centimeter, we go for excisional biopsy. And if it is more than 1 centimeter, we go for incisional biopsy. And in incisional biopsy, if dysplasia is present, we go for total excision and other antioxidants. And if dysplasia is absent, we basically maintain with antioxidants. Basically, what we studied in the previous slides, we have just put it here in different sections. That's all. Okay. So basically, you need to understand that basically for leukoplakia, the line of management is topical antioxidants, topical and systemic antioxidants. That is the main line of treatment. In this context, again, I need to also mention on hairy leukoplakia. Hairy leukoplakia can also be asked. Hairy leukoplakia, don't think that it is a type of leukoplakia, but when the appearance wise, it looks like leukoplakia, hence the name. Just if you get a question on hairy leukoplakia, just understand this 3 or 4 points. One, it is caused by Epstein-Barr virus. Second, it is seen in immunocompromised patient, especially HIV patient. Third, it is having a corrugated or a hairy or leathery texture. And fourth, it is most commonly seen in the lateral quarter of the tongue. These 3 points are enough because it is mostly asked as a 3-mark question. Proliferative varicose leukoplakia also has been asked as a question. So if you're getting a question on proliferative varicose, as I mentioned earlier, it's just still in a debatable thing whether proliferative varicose has to be added in the leukoplakia's classification, because it is very commonly caused by papillomavirus. Here you can see there is only 35% of chance that it is caused by tobacco. Mainly it has been mentioned because of genetic mutation or because of human papillomavirus. It is seen as a rough wart, white plaques on the gums, tongue or gingiva, and it is having a high malignant transformation. Histopath and all those things, we can just mention what we studied in leukoplakia itself. Almost it is very similar to what we studied in leukoplakia. Okay. In the previous slide, we studied about hairy leukoplakia. In this context, I just need to mention one more terminology, that is, see, I will discuss whichever pathologies are coming in mind, okay, when we'll just connect and study. Hairy tongue is again one more thing which can be asked for an next year exam. Hairy tongue is a condition where it is actually because of enlargement of filiform papillae, and when it is getting stained by food and other debris, that is what we call hairy tongue. So that don't get confused with hairy tongue and hairy leukoplakia. That's why I just mentioned it. Erythroplakia is asked. Erythroplakia, you can write almost the same thing. Everything which we study in leukoplakia, you can just replicate here. But the definition, this is the definition given by WHO: bright red velvety plaque, okay, which cannot be characterized. And the classification is also very much similar to leukoplakia: homogeneous leukoplakia, erythroplakia, and granular or speckled leukoplakia. This is the classification of erythroplakia. Candida leukoplakia, I'm not discussing here because I think it must have been discussed in white lesions. Candida leukoplakia, chronic hyperplastic candidiasis is again a very important question, which is not scrapable. And here we can see the candidal hyphae penetrating into the epithelial cells. And so this I'm just skipping. Okay, so the another question which was asked was Plummer-Wilson syndrome, which is a type of, it's coming under the potentially malignant disorders. So just you need to mention about the classic triad, that is iron deficiency anemia, dysphagia, and upper esophageal webs. Okay, so these are the most important, or these are the three triads. Additionally, you can also have other findings, oral findings like glossitis, angular cheilitis, koilonychia. In fact, there was one question which I remember, like it was asked 2 or 3 years back, and the question was oral manifestations of anemia. Here also you can mention the same thing, that is glossitis, angular cheilitis, superadded fungal infection. Then these are the things which are coming as answer for that question also. Okay. Actinic cheilitis, again, it is not asked, but yes, there is a chance for actinic cheilitis. It's otherwise called the solar cheilitis of farmer's lip, very commonly seen in people who are, it's commonly seen in the lower lips, very commonly seen because of the exposure to the UV rays. Okay. And it is seen in the lower lip mostly by dry cracked skin that progresses to rough, scaly sandpaper-like patches. Often it is asked for entrance. Sandpaper-like patches are seen in which conditions? So it's seen in actinic cheilitis. It's mainly because of prolonged sun exposure. The biopsy is way for the diagnosis. Basically, we can go for what we see here is also the features of dysplasia, and you can go for certain medications like topical 5-fluorouracil, Imcumod, laser therapy, excision, etc. Other treatment modalities. Smoker's palate, yes. This is all. This one I think was asked once in Amrita. Okay, but in Kuhas it's not asked. So it's again otherwise called nicotinamide stomatitis. Okay, it was actually this term was introduced by Thoma in the year 1941, but the classification was given by Greenberg et al., where we have grade 1, where we have red dot openings on the hard palate. You know what are these red dots? Red dots are basically the orifices of the minor salivary gland. Because of the heat of the smoke, it gets inflamed. Those inflamed orifices of the minor salivary gland is what we see as this pinpoint red spots. Grade 2 is where we have papules with central umbilication of fissuring. Grade 3 is again you have papules of size more than 5 millimeter with umbilications 2 to 3 millimeter. So there's a classification. Another one very similar classification you must be knowing. Like we see there's red dots and all those things. Do you remember what is that classification? It's dengue stomatitis again. Okay, dengue stomatitis also is one question. So in grading of dengue stomatitis also there is few similarities with that of smoker's palate. Grade 1 is pinpoint erythematous area, grade 2 is diffuse erythematous area, and grade 3 is nodular or granular appearance. So basically both are having some similarities. Okay, So, now we're going to the next very important section, lichen planus, which was introduced in the year 1869 by a person called as Erasmus Wilson, but it was he was not having an idea of what it is, so he felt like it looked like a shape of an algae. So the name flat tremose, lichen means tremose and planus means flat. Asen has given a definition. What is it saying? This chronic or inflammatory disease affecting the stratified squamous epithelia, usually skin, mucous membrane. See, what is the etiology of lichen planus? Etiology of lichen planus is that it is a type of autoimmune disorder. To be a little more specific, it is more of like an immune-mediated response, where what is happening is the keratinocytes or the epithelial cells are here misdiagnosed as antigen. Cytotoxic T cells are coming and causing apoptosis. That is the simplest way of explaining what is the pathogenesis of or lichen planus. But this process of why this keratinocyte is acting as an antigen, we are not very sure. But it has been suggested that these all could be the etiological factors. Genetics, stress, trauma, diabetes and hypertension, hepatitis C, etc. So here, this is another short video. Here, this is an epithelial layer where we have got the basement membrane, and these are the hemidesmosomes. Here, these are the melanocytes. So what is happening in a normal condition is that when your cell is attacked by a particular bacteria or a virus, what happens is the antigen presenting cells will just expose that antigen, and so by seeing this, the cytotoxic T cells are coming, attaching, releasing a lot of enzyme. One is perforin and granzyme. Perforin causes the perforation of the cells, and granzyme just goes and destroys the cell. Apart from this, they are also releasing other cytokines, also tumor necrotic factor alpha, interleukin. So basically what is happening, this is the basic mechanism of immunity which is happening in your body. In the same way here, what happens in the lichen planus, epithelial keratinocytes are misdiagnosed as antigens. The cytotoxic T cells are coming, attaching, and it is releasing cytokines. This attracts other cytotoxic T cells also, and hence it is causing the destruction. Here we can see during the destruction, because of this inflammatory change, what is happening is the melanocytes which are present there. The melanocytes which are present there, they are also forced to produce more amount of melanin. This is what we call post-inflammatory melanosis. Okay, it's called post-inflammatory melanosis. So that is the reason why one very important aspect of lichen planus is its purple color. Okay. Now coming on to the demographics and the clinical features, you can just mention, you can see it's very highly seen, like 1 to 2% general population is like a huge number. Prevalence of 0.1 to 4%, having 35% of cutaneous only, 25% oral mucosa, and yeah, this is how it is seen, because it is a mucocutaneous disorder, and the age is very commonly in the 40 to 70 years. Okay, and it is having a very high female predominance. See, if you get a question on autoimmunity, നിങ്ങൾക്ക് കണ്ണടച്ചിട്ട് നിങ്ങൾക്ക് എന്ത് എഴുതാം, female predominance എഴുതാം, because most of the autoimmune disorders are very predominantly seen in the females. Now coming on the clinical features, we can just put it into two headings. One is the skin, nail and hair manifestation. The other one is oral manifestation. Skin, hair and nail manifestation. First you can write skin, you can talk about as 6 P's. In some textbook it is only 4 P's, 4P or 6P, anything is fine. 6 P's are planar, polygonal, pruritic, purple, pruritic, plaque type and papular. So these are the 6 P's, and certain textbooks there is no this plaque and planar is not there. So that's how it is 4 P's. Lichen planopilaris, and in the skin also it is commonly seen in the flexor aspect of the arms, extensor aspect of the legs, lower central back region. Hair loss can also be seen, patchy hair loss, that's what we call lichen planopilaris. A nail can be involved, there can be nail loss or ridging of the nails, that's what we call onycholysis and onychorhexis. Now coming into oral mucosal involvement, basically you need to write about the classification, or not classification, types of like oral lichen planus, that will come to it. Before that, please understand that there is something called a Scorbunus phenomenon, which can also be asked as a 3-mark question, which basically means that micro trauma can aggravate the lesion. That is the word mean. That is the reason why we very commonly see the lichen planus in the buccal mucosa, because more the chances for trauma is on seen in the, because of the occlusal, this thing you can see on the buccal mucosa. And coming on to the types of the oral mucosa, it is classified by Van der Waals into reticular, papilla, plaque, bullous, erosive, and atrophic. So this is how it looks like. Papilla, which is seen as white raised area. Reticular is the most commonest type, where you can see interlacing white carotid lines, and there is a name given to it, Wickham stripe, which can also be asked as a short note. It was introduced by a person called as Hendrik Wickham. Okay, plaque type is again flat, little more bigger in size. Atrophic is where you can see red areas which is surrounded by white striae, and erosive is where you can see it as an erythematous or ulcerated area. And when the gingiva is involved, becomes reddish, or there is a desquamation of the epithelium, and this is what we call desquamated gingivitis. When bullous is another form where you can see it as a bullae, which is a fluid-filled blister more than 1 centimeter. So please note that desquamated gingivitis can also be asked as a short note. So I put desquamated gingivitis also. Desquamated gingivitis is not a disease condition. So please, most of the students have a misconcept that desquamated gingivitis is it's a clinical manifestation. It could be a clinical manifestation of different conditions. For example, mucous membrane pemphigoid, oral lichen planus, pemphigus vulgaris, and linear IG. These are the most commonly mentioned conditions where you can see desquamated gingivitis. Again, differential diagnosis, as I mentioned, right? Two differential diagnoses. One is lichenoid reaction. What is lichenoid reaction? Sounds very similar to lichen planus. Yes, in clinically also it looks very much similar to lichen planus. But unlike lichen planus, in lichenoid reaction, it is because of certain allergic or hypersensitive reaction to certain etiological agent. It could be because of contact or something, to having some drugs. So that is what we call lichenoid reaction. So how we can differentiate? Lichenoid reaction is mostly seen unilaterally. That is one point. Second point, you can say lichenoid reaction is always associated with an etiology. So if you remove the etiology, we can just solve the problem. Homogeneous leukoplakia, you can say that homogeneous leukoplakia is seen associated with tobacco. Lichen planus is seen bilaterally. Lichen planus is having the typical Wickham striae. That's it. Just write 2 points. That's enough. Histopathology, just think about the pathogens which I mentioned. There are a lot of inflammatory cells. Yes, inflammatory cell infiltrate will be there. There will be a degeneration or liquefaction of the basement membrane. That is another point. They will be sawtooth like ridges, and they will also, basal keratinosis. Because of the disruption, you can also see certain space or clefts. That is what we call Max Joseph space. So just write 2 or 3 points in histopathology. Don't break your head for histopathology. Management. Okay, management. Here it is steroids. See, please keep this point in your mind when you are dealing with any autoimmune disorder, that will be lichen, pemphigus, or rheumatoid, or whatever it is. Please understand that basically for all these autoimmune disorders, the commonly given drugs are, one is corticosteroids, second are immunosuppressants and immunomodulators. So this is the same thing which is applicable here also. First we go for topical, triamcinolone, fluconazole, clobetasol. Study the dosage and all those things. 0.1% for triamcinolone. Fluocinolone, it is 0.025. Clobetasol, it is 0.05. For systemic, which is prednisolone, 40 to 80 mg is the maximum dose that we give at a dosage of 1 to 2 mg per kg. We go for immunosuppressive and modulators also. For example, cyclosporin, azathioprine, levamisole, chloroquine. These are certain immunosuppressives and immunomodulators. So these all are the medications which we need to by heart. And other treatment modalities include photodynamic therapy, excision, carbon dioxide laser, cryosurgery. Certain antibiotics can also be given. Anti-malarial drugs can be given. Thalidomide can be given. Dapsone can be given. Levamisole can be given. So these are all certain drugs. So please be sure that you know all this medication. Okay. So as I mentioned earlier, there is something called as oral lichenoid reaction also, which looks very much similar to lichen planus clinically. So this can also be asked. It's not yet asked, but yes, there is a chance. So it is basically divided, as I told, when there is contact. For example, dental adhesive, dental metals. We often hear the term, amalgam-induced lichenoid reaction. Amalgam fillings can cause drug reactions associated with certain food items. Graft versus host disease, lichenoid reaction, beetle quid. We normally also have a terminology called tobacco-induced lichenoid reaction. Okay, so these are the types of oral lichen alteration. If you get a question or 3-mark question on oral lichen alteration, please be informed. This is the answer. Okay, this is what I just previously mentioned about oral lichen. It's difficult to differentiate, but it is most commonly seen unilaterally. Location near to restorative, patch test is positive. Management is you just remove the etiological agent and you can go for the topical steroid and modulators and which we discussed earlier for the lichen planus. So please keep this thing in your mind. Leukoplakia, the main line of treatment is antioxidants, okay, fungal and antioxidants. And leukoplakia, the mainstay of treatment is steroids with immunomodulators and immunosuppressants. So, OSMF, that's another one very important topic. Often students comment and it's very difficult to remember the definition of OSMF. In fact, it is very easy. See, let's go through the definition. It's a chronic insidious condition. Insidious, you must have heard, at least the movie Insidious. Insidious is nothing but hidden. So most often the condition, the patient won't be knowing that he is having this condition. But mostly the patient come to it as a very late stage when the mouth opening is very minimal. So it is a chronic insidious disease affecting any part of the oral cavity and sometimes pharynx. There is no need of any explanation. Although occasionally associated with vesicle formation. ചിലപ്പോഴൊക്കെ vesicle formation ഉണ്ടാവാം, but എന്താണ് അവിടെ actually നടക്കുന്നത്? There is an juxtaepithelial inflammatory reaction just below the epithelial layer. There is an inflammatory reaction. Because of this inflammatory reaction, there is increased amount of collagen deposition. There is fibroelastic change in the lamina propria, and as a result, there is epithelial atrophy. Epithelial atrophy means the epithelial size has been reduced. There are loss of epithelial cells, stiffness, causing trismus and inability to eat. This is the definition. So if you just understand the meaning, it will be easy for you to understand. OSMF is a very common topic. I think you must be studying from your second year. So the most important causes are recurrent, nutritional deficiency, vitamin C, autoimmunity, and genetic susceptibility. So, arachnoids contain alkaloids and flavonoids, where alkaloids mainly stimulate the collagen, and flavonoids basically it will reduce the destruction of the collagen. So there are many flowcharts which is showing how it is acting or how this mechanism is happening. But I would say from an oral medicine point of view, let's focus more on the clinical features. But still, this is how there is an increase in the collagen synthesis because of the inflammatory reaction. One very important inflammatory mediator is TGF beta that is actually playing a very crucial role. So it actually stimulates the procollagen genes, which are basically the procollagen C proteinase and procollagen N proteinase. I haven't added it here. So basically it is actually activating these genes, and at the end result, the collagen production is increasing. That's it. You could just need to understand that much. And in the same way, this tumor TGF beta itself, which is a very important inflammatory mediators, it is also inhibiting the destruction. That is mainly by the TIMP and PAI. TIMP is tissue inhibitor metalloproteinase and plasminogen activator inhibitor. So basically it inhibits the formation of pre-plasminogen to plasmin. So basically plasmin is very important, which helps in the destruction of the collagenase. So that is not happening. So at the end result, what is happening is there is a very increased amount of collagen is deposited. So pathogenesis, just 1 or 2 flowcharts are enough, I would guess, for the oral medicine answer. Let's go to the clinical features, which is more important. It is seen between the age of 20 to 40, and the early symptoms include all those things you have already studied in your textbook: blanching, pallor, excessive salivation, burning. Here you can see both hyper and hypopigmentation. Late symptoms include limited mouth opening, fibrous band, shrunken uvula, depapillation of tongue, difficulty for whistling, difficulty in tongue movements, and hearing problems. These are some other late symptoms. Next, staging. Staging, I would say you study whichever stage you want. Here, just for you to make you happy, I've just put the most easiest and simplest staging. There are some 15 or 20 staging for oral submucous fibrosis. This is a class staging by Pinborg, which is very simple to study. Stage 1 is stomatitis, where there are early inflammation, vesicles or ulcers. Stage 2 is fibrosis, and stage 3 you have other associated premalignant lesions or other conditions like speech or hearing issues. And interincisal opening, group 1 greater than 35, group 2 26 to 35, and group 3 is less than 25 millimeter. These are the lab investigation. raised ESRs like eosinophilia, microcytosis, decreased protein and vitamin B complex. Histopathology, I would say OSMF is not actually a histopathological diagnosis. OSMF is a clinical diagnosis. But if you're writing the histopathology, just revise, just look into the definition. That's enough. You see epithelial atrophy, you see increased keratinization, there is increased inflammation, and there is dense collagen in the connective tissue. So, definition on if you just revise it, you get the answer to the histopathology. It is that simple. Differential diagnosis anemia, you can differentiate, you can just see the palpable pallor is one feature which you see in anemia, but you can see pallor in OSMF also, but the palpebral conjunctiva will not show pallor if it is OSMF, because OSMF is only restricted to the oral cavity. Second way by which you can differentiate it is you can just go for a blood test where you can see that there is a reduced RBC count or HP. And third way is you can say that OSMF is associated with the use of recurrent. Three things. Scleroderma. Again, I would just want to add another one. Scleroderma can also be asked as a bouncer question. Scleroderma, the question which will be asked is oral manifestation of scleroderma. Scleroderma is a condition where there is a progressive fibrosis. There is what we call some irregularities in the immunity, and also the microvasculature is also being affected. So clinically, the fibrosis is there in scleroderma and OSMF also. So how can you differentiate it? Scleroderma is a condition where you can see this fibrosis in other parts of the body also, but OSMF is restricted only to the oral cavity. Second way by which you can differentiate is OSMF is associated with the use of recurrent. 2 points, that's it, enough. Now coming into the question, oral manifestation, you can see certain terminologies, if you can remember, it was nice. Mask-like face, that is one thing. You can say expressionless face will be present in scleroderma. Then you can see a mouse-like face because of the obliteration nasolabial fold. You can see it will look like a mouse-like face. Third is mouth opening is very less. You can, it's called purse string appearance. So this, you can just remember this beautiful three terminologies. It will be easy. Then I told it's similar to OSMF. So you can see fibrous bands, difficulty in mouth opening, limited tongue movement, and the gingiva and periodontium can also be affected. Some cases the minor salivary gland can be affected. In that case, it mimics that of Sjogren syndrome. So this is a nutshell about the clinical features of scleroderma. So that also can be asked as a bouncer question. Okay, fine. Management. Please study the management which from the textbook, whichever textbook you are studying, basically stoppage of the habit here, or you can write about the 5 A's, okay, in OSMF also. Antioxidants, then iron supplements, topical corticosteroids, intra-arterial steroids, betnosol, dexamethasone, immunomodulators, levamisole, enzymes like hyaluronidase, collagenase, chymotrypsin, interferon gamma, placental extract, pentoxifilin. Pentoxifilin is a drug is used for cardiac conditions. It increases the vascularity. So that is also one thing. COX-2 inhibitors, immunized cow's milk is also another condition. Other treatment modalities, surgery, laser, therapeutic USG. Please be informed that the USG can also be used for therapeutic purpose, not only for the diagnostic purpose. Now coming on to the next section, oral cancer, I'll go a little fast because it's already 7:57. We'll finish in 10 minutes. So oral cancer, essay as an oral cancer, investigate. That's one question which was in KUHAS. I remember maybe 2 or 3 years back, the question was investigation oral cancer. I think most of the answer sheets which I corrected gave only 2 answers. One is biopsy and the other one is a TNM staging. But we have other lots of investigations in oral cancer that also we'll discuss. TNM staging is a very important question, which is something which you need to by heart. There is nothing else we can do. And in radiotherapy, there are a few questions like recurrence effect of radiation, oral structures, brachytherapy, anti-cancer drug, acute radiation syndrome, chemopreventive drugs. So these topics, I think, were already covered for you in radiation biology. So those slides, I'll just skip a bit fast. Now coming into oral cancer, definition is very important. Start with this definition. Oral cancer is an uncontrolled growth of oral tissues that persists even after initiating factors removed. The most common type is squamous cell carcinoma originating from the surface epithelium. There is a pretty easy definition to remember. Etiology, again, a lot of things similar to that of leukoplegia. We have tobacco, just write some 2 or 3 points on tobacco, alcohol, betel quid, papilloma virus, chronic irritation, mostly because of sharp tooth or sharp processes, chronic trauma can cause it. Then genetics and diet. Basically, if you're having some genetic mutations, or if you're having a lot of immunocompromised situation, that also can cause. UV for lip cancer. The previous slide we discussed something called as actinic cheilitis, which could also end up in a malignancy. One very easy thing which you can study is one for a few textbooks suggest a 6 S's. Okay, I hope you know what all are 6 S's: spirit, smoking, sunlight, sharp tooth, syphilis. Okay, so these are the 6 S's. So you can study that also, whichever is comfortable for you. You can apply it in your answer. Clinical features, it's 11.5 adults per 1 lakh. So, and it is having a very high male predominant. Do you know which is the most commonest cancer in India? Is it oral cancer? Okay. The answer is not oral cancer. It is breast cancer in females and lung cancer in males. So please be informed. So these are the clinical features: early signs and late signs. Early signs, persistent red or white patch. There is nothing is there to explain it. So that is the reason why I'm reading. Okay, it's all simple things which I've already studied: progressive swelling or enlargement, unusual surface changes, sudden tooth mobility, unusual oral bleeding, prolonged hoarseness of the voice, late stage is called induration, paresthesia, airway obstruction, chronic earache, trismus and dysphagia, cervical lymphadenopathy, persistent pain or referred pain, altered vision, and epiphore. Okay. So this is very important. TNM stage, it's been asked, I think, 2 times in class. Where T represents the tumor size, we have got T1, T2, T3, T4. We have already studied this. We just need to by heart it. There is no other way. T1 is below 2. T2 is moved between 2 to 4. T3 is tumor size is greater than 4. And T4 is when there is invasion of distant structure. In some textbook, there is T4A and T4B. Okay. And N0, there is no palpable lymph node. N1 is we have ipsilateral lymph node, and N2 itself is having N2A, N2B, N2C. I think when I copied it, this is a kind of little older classification. N2A is basically we have single ipsilateral, that is between 3 to 6, and N2B is we have got more than one ipsilateral lymph node, which is between the size of 3 to 6, and N2C is when we have got bilateral or contralateral lymph node. Again, the size is less than between 3 to 6, and N3 is when we have the lymph node size greater than 6 centimeters. Okay, this classification which is there in the slide, there are a few mistakes in it. So when I'm just sharing the PowerPoint slide, I'll share with you the correct classification. I'll add the correct classification and I'll share it with you, because normally it is not just N2A, N2B, N2C is there, and N3 is there. M is correct here. M0 where you have got no distant metastasis, and M1 where you have got a evidence of metastasis. But in N2 there is a mistake, and T4 also there is, it's again classified into T4A and T4B. Okay, fine. So that I'll share with the new one. Now, investigation, that was a question which I mentioned earlier, which was asked in FUHAS, and most of them have not written about anything about the radiographic investigations. And IOPA can be taken from starting from IOP, and occlusal can be taken. You can go for other radiographs like CT also. Here, radiographs mainly help us to know what is the bone invasion and what is the pattern of destruction of the bony trabeculae. Occlusal radiograph can also be taken, where you can see ill-defined destruction with ragged borders. You can also see the thinning of the cortical bone, and when the tooth is involved, you can see a tooth floating in your appearance also. CT and MRI is again preferred. Mainly in CT and MRI, we can exactly know what is the bony extent, whether there is any metastasis. We can also assess the lymph node status, because when you have a metastasis, there will be a lot of changes in the lymph node also. Mainly the lymph nodes are having more of like an oval shape. So when it goes to a metastasis, the size will go more into a spherical shape. So these are some various radiographic factors which you can assess in a lymph node when there is a metastasis. Okay, so PET scan is again another investigation. These things were not written by anyone in the answer sheet which I checked. Only the vital staining, biopsy, and TNM stage. PET scan is again another one technique. PET scan is otherwise called positron emission tomography. Positron emission tomography is where you are injecting a radioactive isotope. Often it is asked for your entrance exam, which is the isotope we use, 18Ftg. So where 18F fluorine is the radioactive isotope and deoxyglucose is the biological molecule. So the basic mechanism is when there is more amount of division, when there is more amount of glucose requirement, these particular radioactive isotopes are going and it is depositing there. We know that when there is a mitosis, there is an increased division, hence requiring more amount of glucose. So the deoxyglucose will take this 18F to the particular area where there is more amount of division. This 18F will release a positron, which is actually an electron with a positive charge. It will go interact with a nearby electron, and as a result, a photon is produced, which goes in 180 degrees. So this photon is captured by the receptor, and that's how we get the image. So we get a clear idea where all more division is happening. So it can also be used as a investigation. So these all things also need to be added in the answer. Others are vital staining, which I've already mentioned earlier. Another one is biopsy. I already mentioned when the dysplastic cells which are breaking the basement membrane and going to the connective tissue. That is what is happening. And based on the histopathology, it is classified into well differential, moderate differential, poorly differentiated. Okay. Management, surgery, radiotherapy, chemotherapy, immunotherapy. Radiotherapy is one of the most important. We can give it as an external beam radiotherapy, or it can be also be given as brachytherapy. External beam radiotherapy basically means the source of the radiation is kept outside. Brachytherapy means the source of the radiation is kept into or in close proximity with the tumor cell. So we give external beam radiotherapy in fractions. I don't think it's important at UG level. And this fractionation is also based on 4 hours. And it can be given, I'm not going into detail what are the 4 hours. It can be given as either as a palliative or curative, and it can be given pre-surgically or post-surgically. Brachytherapies have been asked once for your university exam. Brachytherapy is where we keep the radiation source very close or into the tumor, where it is classified into preloaded, afterloaded. I think this must be covered in some other topic. I'm just going a little fast. Low dose rate and medium dose rate, high dose. Low dose rate is 0.8 to 2. Medium is 2 to 12, and high dose rate is more than 12 gray of radiation. Temporary or permanent, interstitial, intracavitary, and surface. This is the basic classification of brachytherapy. Very important. Please note this down. It has been asked. This is something I think was already been taken for you. And question is, what are the deterministic effect of radiation on oral structure? That was a question being asked. It could also be asked that what are the effect of radiotherapy on oral structures? Both carries the same answer. So first is the oral mucous membrane. As I told, the basement membrane is rapidly dividing, so they are very sensitive, causes radiation. Mucositis is the second week. Initially, it actually, once the radiation is stopped, it will also here also. Initially, it is seen as an erythematous area. Later on, you can see an yellowish white pseudomembranous, which is a desquamated epithelium. Another one is taste buds, where you can see degeneration. You can also have a loss of 1,000 to 10,000 times, and normally seen in the second and third week of radiotherapy. Next is salivary gland, very important. You know that radiotherapy causes xerostomia. So basically, we have already studied there is a short-term effect and the long-term effect. So basically, in the acute stage, you can see inflammatory response of the serous acini, but in chronic, when there is more of a chronic type of inflammation, you can see fibrosis, parenchymal degeneration, adiposis, and loss of fine vasculature. So the saliva secretion will be compromised, and that is what we call xerostomia, and it normally resolves in 6 to 12 months. Okay. And when the saliva is reduced, or when there is a xerostomia, what happens is the saliva becomes more viscous. There is loss of buffering capacity, and the pH also will be reduced, and also there is a change in microbial flora. This can cause demineralization and end up in something called as radiation caries, which is another question. So radiation caries is a 3-mark question. So you need to write radiation caries radiation causing this cancer through the previous mechanism. It is divided into type 1, type 2, type 3. Type 1 is widespread widespread superficial lesion. Type 2 is, you can see mostly in the cementum and dentin in the cervical area. And type 3 is where there is a dark pigmentation which is involving the entire crown. So these are the 3 types. So please be informed. This is asked as a 3-mark question. Next is on the effect of teeth. Before calcification can cause the destruction of tooth bud. If it is happening after the calcification, can cause retarded teeth, dwarf tooth, failure to form monomode tooth development, and in pulp, mostly it causes progressive fibroatrophy. Okay. Bone, as you know, osteoradionecrosis, I'm not going to detail. Basically, remember these 3 H's: hypoxic, hypocellular, hypovascularity, the loss of osteoblastic and osteoclastic activity, and also the marrow space is replaced by fatty marrow and fibrous connective tissue. So as a result, only we have this hypoxia, hypocellularity, hypovascularity. And as a result, if there is some trauma or something, and if the mucosa is, mucosa is getting torn, and if the necrotic bone is exposed outside, that is what we call osteoradionecrosis. And again, in the latest edition of this Burkitt, they've also introduced one more, that is muscles. And when there is a muscle involvement, it can also cause trismus. So that is again another one feature of action of radiotherapy in radiation on oral structures. So acute radiation syndrome is again one question, 3-mark question. Please write down what is given in the slide. Acute radiation syndrome is a collection of signs and symptoms experienced after brief whole body exposure. 1 to 2 grade prodromal symptoms, 2 to 4 mild hematopoietic symptoms, 4 to 7 severe hematopoietic syndrome, 7 to 15 we have gastrointestinal, and 50 cardiovascular and CNS symptoms. Once one question was asked from what all are the anti-cancer drugs. This is again something which you need to by heart. It is classified by anti-metabolites, antibiotics, hormones, plant products, and alkylating agents. It's there in your pharmacology textbook. You just need to study that because it was once asked as a bouncer question. Okay. So these are the drugs which we give for a cancer treatment. Next is chemopreventive drugs. This also was asked. Chemopreventive drugs means what? It is not actually given for cancer. It is actually given for this all this premalignant lesion and conditions so that it doesn't go into a progress into cancer. It also is having a classification. Please just write what is given in the slide. That's enough. Hormonal agents, synthetic drugs, diet-related agents, vaccines or biologicals. And by mechanism, it is divided by antioxidants and inducers, anti-inflammatory, and apoptosis inducers. So these are the classification of chemopreventive drugs. Basically, we have a set of antioxidants, which even if you can't remember all those things, please remember that antioxidants is one set of drugs which we can give as a chemopreventive. Antioxidants, I'm not sure whether you will get a question on antioxidants, but I've just put the slide so that in case you get a question on antioxidants, you can write. Antioxidants, at least you know few names, that is the name of certain vitamins. So by mechanism, primary antioxidants, secondary antioxidants, by solubility, hydrophilic and lipophilic. By source, we have got endogenous enzymatic and non-enzymatic. So basically, we have got the vitamin A, C, and all the lycopene, all those things you can write. By molecular size, small molecule, large molecule. And in small molecule, we have got the certain vitamin C. And in large molecules, we have got certain enzymes like superoxide dismutase, catalase, etc. So these are the antioxidants. So there's antioxidants and chemopreventive drugs. You just will be sharing the slide. So you just need to study what is given in this slide. That's enough. That's enough. Nothing else. So that's about the drugs. So yeah, that's about my presentation. All the best for your exams. Really sorry for being a bit late. Speak well. Hope a delicious dinner is waiting for you. Thank you so much.
Thank you so much, Dr. Joseph Johnny. And yes, you have elaborately, explained all the questions that has been raised for these 2 topics. And it's not an easy task. It's a Herculean task to, concise these 2 topics into, a 45-minute session. So thank you so much, Dr. Joseph Johnny. And over the chat box, I think there are no questions that has been raised so far. If any queries regarding both the sessions, that is, the previous session, we had Dr. Ashwati K. Vijayan speaking about trauma, sinus imaging, and fibrosis lesions. And Dr. Joseph Johnny had spoken about OPMD and oral cancer. If you have any queries regarding both these topics, you're pleased to, raise it here. Meanwhile, till then, I will just share a certificate of appreciation on behalf of Azizia Dental College as well as from ASMIC. Dr. Ashwati K. Vijayan, you're
Yes.
there?
Yeah.
Okay. Thank you so much, Dr. Ashwati K. Vijayan, for being a valuable for your valuable contribution as a resource person for this rapid review series into 2026.
Yeah, thank you, doctor. Thank you so much.
And over to Dr. Joseph Johnny. Thank you so much for your valuable contribution as a resource person
Thank
for
you.
this rapid
Thank you
review
for the
series.
opportunity. Thank you.
I guess it seems both the sessions were elaborately being compiled and mentioned about all these topics, and I believe so far there are no questions that has been raised. If there are any queries, you're free to ask in the chat box, or even if even our WhatsApp group is there. You may raise your questions there.
This PowerPoint will be shared with the students, right?
Yes, definitely will be shared.
So I'll after this session I'll send you the PowerPoint. So in that there is the TNM staging which I have kept as a bit older one, that I'll add the newer one and I'll share.
Definitely. And if any questions are to be raised, you please, and you may raise your questions in the WhatsApp group itself. And thank you so much. Have a good evening.
Yeah, thank you all. Thank you, Chandler.
Thank you, Doctor.